a quick start. My name's Jacob George from Sydney in Australia, and we've got some very practical case-based management decisions. Thank you to the audience that's still here after a very long day of excellent presentations. And with me, I'm the moderator for the session, but with me, the experts to discuss the three cases need no introduction as they've all spoken at the meeting. They include Professor Raj Reddy from the US, Sengyi Lim from Singapore, Professor Romero Gomez from Spain, and Professor Wei Lai from Beijing, who was our previous speaker. And the three cases we've got, the first one is going to be presented by Dr. Aphinya Lirapun.
Thank you, Mr. Chairman. First of all, I would like to thank the scientific committee for the opportunity to present, to share the case from our center to very fantastic conference. Our patient is a 45-year-old woman who referred from our nephrologist according to her hepatitis C infection. She is a kidney transplant recipient and have been diagnosed chronic hepatitis C since 1998 during her kidney transplant admission. She said to me that she was very lucky because her donor is also C positive. At that long period of time, she did not have any medical advice for chronic hepatitis C. 11 years later, is around 2009, she was referred to our clinic for proper management of chronic hepatitis C. At that period of time, her graft still worked well, and she also took healthy dose of immunosuppressive agents for her kidney transplant status. For the investigation, liver function tests were perfectly normal. SBS antigen and anti-HIV was negative. Ultrasound at rebel normal liver parenchymal. At that period of time, I hope all of you agree with our team that PEG interferon and interferon-based therapy in post-kidney transplantation will transplant kidney still viable, is not effective, and can induce graft dysfunction. So, serial follow-up of liver function tests and liver imaging was suggested. 3 years later, she revisited to our clinic. Her graft was already lost, and she became hemodialysis dependent again. All immunosuppressant was stopped, and she was released to kidney transplantation. She was completely asymptomatic, but recently admitted due to catheter-related sepsis. Her HCV profile was shown. She got a genotype 1A. The virus is rather high, more than 1 million. The liver function test still normal, and also the ultrasound. The fibroscan was done and showed non-significant of any fibrosis. The first question is, what are your management strategy for this patient? First one, any information do you need before the decision making for treatment this patient? When to start the treatment? Now or just postpone? And what the regimen that you prefer in this case, please?
So Raj, may I just ask you the first question? This is, remember, 2009, genotype 1A, high viral load, normal fibroscan, normal liver ultrasound. What would you do in this case? Not on immunosuppressants anymore.
Right. So I guess I have to wind the clock back to 2009 and present options. So it's a non-cirrhotic patient, 1A, high viral load, and at that time we just had interferon and ribavirin, and recognizing, as you pointed out, that we would not want to treat the patient with an interferon regimen post kidney transplant. So that's what we would have, and of course, like others, we've treated a lot of these patients, but in our experience, response rates pre-kidney transplant were low. It's around 10% with genotype 1, and that's maybe because of our population, because in the US, most patients who have CKD are Black Americans due to hypertension and diabetes, and so they had low response rate. So at that time, that was the only option we had. And again, we were limited by not being able to treat them post-transplant with interferon regimen.
I guess the other question really, maybe Sengi, if I can ask you to answer this. Do you think this patient needs treatment? Back in 2009?
Well, I think here the liver disease looks mild, but if she's going to be relisted, I think in Singapore anyway, and at that time with the prospect of Hep C in transplant patients, they would not transplant her with Hep C present. So she would need to be treated and have SVR before they would consider transplantation. Having said that, I think the experience in Asia, well, I don't know about Thailand, but certainly in Singapore, treatment with PER, with reduced dose ribavirin or PEG interferon monotherapy has been quite good and been getting actually SVR rates of around 70%. So for this patient, I would actually check the IL-28B status, and that could be a decision breaker for you, because if she's a CC genotype, she's likely to be a good responder. You could either use reduced dose ribavirin or just PEG interferon monotherapy and then manage accordingly. Of course, you have to manage the anemia quite aggressively.
Raj, did you have
I
a
just want to add, it's an interesting question you asked as to whether this patient deserves to be treated. So if one were to look at liver disease and low response rates, you might say, well, what's the point in treating? Is there a need for treatment? But then there's enough data to suggest that HCV kidney transplant recipients, independent of liver disease, do poorly or less well compared to those who receive kidney transplant for non-HCV reasons, suggesting that there might be an impact of HCV on extrahepatic disease, in that HCV may be contributing to kidney disease. There's actually a higher prevalence of diabetes post-kidney transplant, whether HCV is contributing to diabetes as an extrahepatic manifestation. So there are a lot of non-hepatic issues related to hepatitis C in the kidney transplant recipient that would suggest that perhaps you're better off treating them independent of severity of disease.
So I guess the summary of that is we would think about treating this patient back in 2009 with the drugs that we had, A, because it might, if she wouldn't be listed for transplant, and also because of the poor survival relative to non-HCV infected patients post-kidney transplant.
Okay. So this summarize of this case, zero prevalence in chronic hepatitis C from dialysis register is around 4%. And according to impact of chronic hepatitis C on mortality in patients who got dialysis, not only liver-related death and also cardiovascular disease. So initiation of treatment was discussed in this patient. SVR rate across the recent meta-analysis from PEG interferon and ribavirin in the clinical study across the world is around 80%, 60%, because it includes the not many number of cases from Asia, but significant very dropout rate is around 25%. In this case, after totally we discussed with risk benefit with patients, we designed to start pegylated interferon alpha 2A in the dose of 135 micrograms per week, plus very small dose of ribavirin, 200 milligram alternate day. Unfortunately, when treatment was continued, she facing with severe hemolysis on week 12. And so ribavirin was stopped, and pegylated interferon monotherapy was continued entire 48 weeks of treatment. She only got PEVR on week 12, but negative SVRNA at week 24. Unfortunately, when we stopped the treatment, her virus was relapsed on since 3 months after stop treatment. Now her liver function is still normal, and repeat of fibroscan still non-significant fibrosis. The problem list of this patient now is chronic hepatitis C genotype 1A, non-cirrhotic, with treatment experience, and ESRD patient on waiting list of kidney transplantation. Now, the last question is, what is your strategy to management this patient now? Any information you want to need? When, now, or wait for a new regimen, or just wait until she got transplant and repeat DAA after that, and which regimen you prefer? I will overview about the available agent now in Southeast Asia. We also got peg interferon, ribavirin, boceprevir, sofosbuvir, and the catasvir for treatment of chronic hepatitis C genotype 1 now.
So Manuel, if this patient was yours back in Sevilla, what would you do? Failed interferon treatment. I guess the first question is, would you have used the same doses of drugs when you started the PEG-RIBA?
In this group, we try to reduce the dose to 135 milligrams per week. Also using PEG-alpha-2B, but in Spain, the majority of them were treated with PEG-alpha-2A using low dose. But at this time, fortunately we can move to the future, no? And we can make decision in a better manner.
One other question is, Spain's got very high donor rates.
Yes.
Would a patient who's Hep C positive be precluded from a transplant because they've got Hep C, as it would in Singapore?
For extrahepatic disease, no, but we are trying in the near future to include this type of patient. At this moment, just for patients with liver disease related to hepatitis C, she could receive an hepatitis C organ and to be treated later. But for the extrahepatic transplantation, solid organ transplantation is forbidden now.
Okay. So in Spain, now it's 2016, what regimen would you use in this patient?
I think we need to use sofosbuvir, low doses, 200 milligrams, plus daclatasvir is a very nice option because percentile ribavirin non-responders, a partial responder with later relapse is not an option. Boceprevir doesn't play any role, and perhaps is DAA using the combination of low dose sofosbuvir plus daclatasvir.
So Professor Weilai, in China, is sofosbuvir daclatasvir approved currently?
Not yet. And currently, the standard of care are still for the peg interferon and the low dose ribavirin for this kind of patients. And however, in the nearby countries, including in Thailand and Laos and India, already and the drugs approved, some drugs approved. So therefore, we have some patients that they got drugs DAA in these countries. In our hospitals, and our hospital has the big dialysis center, and we have 37 patients and infected with the HCV, and so they also used the sofosbuvir or daclatasvir for the patients.
So you get it externally,
Yeah,
the drug?
Yeah,
Okay. So I guess the answer is pretty clear. Today we would treat, and we'd ideally treat with sofosbuvir and daclatasvir.
Yeah, I think the additional thing, just to interrupt there, I think Naruto Road did a good editorial recently on this combination in renal transplant patients, showing it's quite safe. So I think it's good to know that you can use that in the post-transplant setting as well. So if you need to transplant, then you go ahead and treat.
So it's very interesting about the different opinions from the various countries. We would not treat this patient pre-transplant. Just to give you a sense, in our neighboring state, if you're willing to take a C-positive kidney, the waiting time is 7 months. If you're not willing to take a C-positive kidney, the waiting time is 7 years. So we would not treat this patient. In fact, we actually, as I presented yesterday, we wrote a perspective, or my colleague wrote a perspective on this. There's quite a few C-positive kidneys that have been thrown away in the bucket. So we are actually now embarking on a protocol. We're going to give C-positive kidneys to C-negative recipients and treat them after transplant. I would compliment Manuel on using sofosbuvir in this patient. I would not. I would use the 3DA regimen in this patient, which is readily available to us, and it's been shown to work well in those with chronic kidney disease. That's quite safely. So if I had a live donor, that's what I would do. Treat the patient with 3DA regimen and then do a live donor transplant.
I think, to be fair, the options we've got are only those 4. So if you had only those 4 options,
So if I was going to pick something out there,
Yeah.
I would use
Yeah.
peginterferon, ribavirin, and declarasphere.
and daclitasphere.
Yeah, without
Okay.
sofosbuvir.
And
Have you got
if,
any?
And
would
if you
use-
have
so you'd
any
use
other
ribavirin
choice
with it?
for,
Yes, yes.
and if you have any other choice for this situation, and you will wait for new DAA or just treat now with SOF and Jacaz in this case.
And as Sengji said, there's quite a bit of data. There are actually 2 papers now on successful treatment of hepatitis C post-kidney transplant without interferon regimen. So if one wanted to wait, you could wait till after kidney transplant and do.
Well, I got to ask you here, Raj. So the risk here for sofosbuvir is worsening renal impairment, I presume. They're going to have a transplant anyway. So why not just treat them and then they go for the transplant?
So the question is, I guess it's not necessarily the renal impairment. No one knows the consequences of this metabolite, 007, on non-renal situations. So like, for instance, you saw severe bradyarrhythmia in this patients, and there's blamed on amiodarone. How do you know if you treat renal failure patients that you not have a similar phenomenon outside of the kidney is the question. So there are only limited studies here and there. I think this has to be systematically studied.
It's a very, very interesting discussion, but I would like to focus on this scenario with just these drugs. Of course, if we have the opportunity to treat with grazoprevir, elbasvir, or with the combo of ABI, perhaps we have a better option. But it could be also very interesting, I don't know if out or if beyond of this discussion, the editorial and the case report in Gastro about amiodarone and sofosbuvir toxicity, that seems that the 0077 metabolite is not responsible for cardiac disease, but it's just an hypothesis. No, seems to be more implicated the daclitasphere or the PI.
Okay.
So in the interest of time, we might stop with this case. But I guess briefly to summarize, I think the problem that we have today is we've got quite a few regimens, and this is probably one of the most vexed areas in hepatology, when to treat in patients with renal disease and whether to treat now or after transplantation. So thank you very much for that first presentation. The next case is by Nachaya Chamrunkul. Can we have the slides on the screen, please?
Okay. I would like to present the second case is about HIV/HCV co-infection. The case is a Thai 58-year-old man. He was diagnosed of HIV infection for more than 10 years ago, and he received ARV GPOVR S30 since 2002. His initial CD4 count was 160. He had drug allergy to sulfur group like maculopapular rash. In November 2005, the liver function test showed the transaminitis AST is 106 and ALT 145. Viral profile was performed and anti-HCV positive. Liver ultrasound, no evidence of liver cirrhosis. At that time, we discussed with patient for the treatment. He cannot reimburse or afford any treatment, so we decided to follow up and wait for one day that he can get the treatment. 4 years later, he has a lipodystrophy. The ARV was changed to TDF, lamivudine, and efavirenz. His CD4 count was about 1,200. And liver function test show a little bit transiinitis. The other biochemical test is still within normal limit. In February 2012, he was performed the first fibroscan that showed he has F4 fibrosis. AST about 70 and ALT 65. And we perform fibroscan every year. In the next year, fibroscan was increased to 21.3 and AST show 103 and ALT 87. And we follow up until February 2015. He got a good news that the government provide the treatment for everybody that have anti-HCV positive. Fibroscan at that time is 38 kilopascal. He had a HCV genotype 3 and HCV RNA is about 4 million IU per ml. The unsound showed no evidence of liver cirrhosis. His CD4 count is 1,200. So we don't hesitate to start treatment with pegylated interferon and ribavirin that government provide. This is a chemical of this patient. At the baseline, he didn't have anemia, but low platelet count. His CD4 is 1,200, and we calculate Child-Pugh score is about 6, that Chi-A. After treatment for week 4, he was not achieved the RVR. HCV RNA is 4,000 IU per ml. After 12 weeks, he got anemia from ribavirin, so we decreased the dose of ribavirin from 80 milligram to 600 milligram, and follow up frequently. And week 16, he still had anemia, and we reduced the dose of ribavirin. He was regular follow-up at the ID clinic. The CD4 count was checked every 6 months, and this week, his CD4 count decreased to 250. We do not think about his CD4, and he's still well and can continue the treatment. So in week 33, his CBC showed anemia, and we reduced ribavirin again to 200 milligrams and follow up. In week 41, he had pancytopenia. ANC count is 700. So we decreased dose of pegylated interferon to 135 microgram per week. His HIV viral load is still undetectable, but CD4 is 140. At week 44, we decided to stop treatment. It's due to he got an infection at leg, like a cellulitis. So we consider about infection, so we discussed to the patient and stop the treatment. So point of discussion for this case is safety and efficacy of pegylated interferon and ribavirin combination therapy in HCV HIV co-infection. The first question is, what is the best regimen for this group of patients? You think pegylated interferon and ribavirin for 48 weeks, or wait for DAA, which not available in Thailand now?
So I guess maybe we first start with you, Manuel. In Europe, there's been a lot of experience with FibroScan. This patient went from a FibroScan of 16 in 2012 to 38 in just 3 years. And assuming that the ALT, as far as we know, is between 50 and 100, do you believe that the FibroScan in this patient is actually a reflection of disease progression?
I think so. FibroScan show a major limitation and could fail in many situations, at least in all of them when the liver is playing on different cells, for example, in acute hepatitis or fat in NASH or in steatosis in patients with hepatitis C or bilis, for example, in cholestatic disease, etc. When we perform the first FibroScan, we need to be very cautious with the interpretation of the fibrosis according to FibroScan, and we need absolutely confident with the quality of the FibroScan, taking into account the KPA together with the IQR. Depending on the dispersion of the different shots, we need to be more confident. Taking that this FibroScan was very high quality, the second point is how FibroScan is changing during the evolution of the disease. And I think when in the same center, using the same FibroScan, a patient show an increase in the KPA, I'm sure this disease is growing and this cirrhosis is true and the patient is suffering a relevant disease at this moment.
So Senki, would you agree with that the disease has progressed as rapidly as it would suggest on the FibroScan?
Yeah, I think this patient has a lot of poor risk factors. I mean, first of all, the genotype 3, we know that causes increased rate of fibrosis compared to the other genotypes. Second of all, HIV co-infection, and we already know that this group of patients have more rapid progression than a normal patient. So it's not surprising at all. I'm just surprised chose PEG-RIBA because the baseline platelet count was 76,000, and that's kind of risky to start PEG-RIBA at that sort of level. I think even if this patient didn't have HIV, I would be very reluctant to treat this patient because, you know, he's already got advanced fibrosis, genotype 3 with cirrhosis. You know he's going to be failing treatment.
Raj, how would you manage this patient? Assume that it was, you know, 2012.
Yeah. I guess at that time, that's the best treatment you had. I would agree with what's been stated that this patient did have cirrhosis, quite, you know, advanced in terms of portal hypertension, and not at all surprising given that the natural history of hepatitis C in co-infected patients, and particularly in the background of genotype 3, is of an accelerated nature. So they had no choice but to treat him and then kind of manipulate the drugs to address the hematologic adverse events. So I am also in the same camp as Singji that you could continue to for 48 weeks, but I have a feeling this patient's going to fail therapy. Are you asking if you want to roll over into a DAA at this stage, or see what happens with interferon and ribavirin?
No, I just asked if
we
decide back to February 2015, we have to start treatment or wait for DAA?
No, I would wait for DAAs. I don't think retreating with interferon and ribavirin is going to do anything in this case.
I thought sofosbuvir is already available in Thailand.
It's
no?
not available now.
Oh, all right.
So Manuel, you had a comment?
Yes. Even back into February this year, when you start interferon plus ribavirin, 1 year ago was the last interferon that I prescribed to a patient. I don't treat any more patient with interferon, fortunately, and I hope it could be a reality here in the next few years. But I think if we have no any other possibility to treat a patient, this patient clearly requires treatment. It's GNO3, interferon plus ribavirin is the only one option. We need to use this therapeutic combination with two maximum ideas. The first is the higher efficacy. We need to treat this patient when we have a big opportunity to cure. For example, this patient with decline 3 logs, I'm not sure exactly the viral load at week 12 or 24, but it's mandatory to monitorize and taking decision because we don't need we don't treat any patient that we are not absolutely confident with the idea to achieve SVR. And the second one is the higher safety. We can't transfuse a patient anymore. If a patient is receiving PEG plus RIBA, but the patient develop anemia, we need to stop therapy. The patient is non-responder due to adverse event, but we avoid more adverse event in this scenario in which the achieving of SVR is very rare or nearly impossible.
So, Professor Lai, based on the drop in CD4 count, is that common in your experience?
Yeah, and for these patients, and you can find during the disease progression and the CD4 and the decreased over time. So therefore, and anyway, and currently, and the patients, the majority, and the disease, the progression is for the liver disease. So therefore, and you can find and the increase of the fibrosis count value. So therefore, and for these patients, and we should give the and treatment because they just have the pegneviran and ribavirin. So therefore, and I think it's correct to use the pegneviran and ribavirin to start the treatment. And however, and I'm not sure why we have the extension durations. Actually, we can use the RGD strategy if the patients cannot have the significant reduction of the HSCR, you can switch to the DAA at this time. So of course, and because the patients have the CD4 and the decreased over time, so therefore we have to pick up the regimens and without the drug-drug interaction with the HIV and the treated regimens.
Are there any comments from the audience on this case? If not, thank you very much.
Thank you.
And the last case that we have is going to be presented by Wacharas Charasak Chotiaputra. Sorry about my pronunciation of the Thai names.
So due to we don't have enough time, so I will quick summarize for this case. He is a male, 32 years old. He had beta thalassemia hemoglobin E disease with history of multiple blood transfusion. Since he was 5 years old, he underwent splenectomy for 10 years, and then he developed secondary hemochromatosis for 7 years. He has been diagnosed with Hep C for 5 years. He did not have any symptom at presentation, and he referred for Hep C treatment. His medication were folic for thalassemia, defitelipone for treatment of hemochromatosis, and aspirin for prevention of thrombosis. He did not have any allergy to any medication. Physical examination revealed only moderately pale, mild jaundice, positive for spider nevi, abdomen just liver 1 centimeter below liposome margin. Others were remarkable. His CBC, hemoglobin was 6.8, white cell normal, and platelet was normal. Creatinine was normal. Liver function test showed indirect hyperbilirubinemia. He has mild elevation of AST/ALT. Prothrombin time was normal. So his Hep C was positive. Viral load allowed 2,500,000. His genotype was 3A, and his underwent FibroScan. It showed 14.4 kilopascal. And then he underwent ultrasound sonography of upper abdomen, and it showed a mild cytolytic change. So now he has a problem with thalassemia major with secondary hemochromatosis, and second was chronic Hep C genotype 3A with cirrhosis. My question that is, what is the proper regimen for this patient if he did not have any problem about his budget? He can pay for the treatment because he just want to cure from this disease.
So, Professor Lai, this is right up your alley since you gave the previous talk. What do you think about this patient, and what would you treat, assuming that DAAs, are we assuming that DAAs aren't available, or
Yes.
that the patient can travel and buy it?
That's right.
So and you got DA? for these patients?
I think next month we will got
Next month.
sofosbuvir and daclazazovir.
Long time. So, and you can find these patients in the already in the have the in the resection of the spleen, and currently they have the higher viral load, and the FibroScan is more than 14, and also genotyping 3A, and also an anemia, and the hemoglobin is low. So therefore, and for these patients, and in the previous, if you do not have the DAA, you can just use the paclitaxel and the monotherapy for these patients. And because the genotyping 3 also and sensitive to the interferon, and the interferon, paclitaxel and the monotherapy also can induce the high SVR. The question is, and we should and low, and how about the IL-28B polymorphism, and before we give the patients the paclitaxel, if the patients with the CCLL and is correct and the regimen. Otherwise, if the patients is TT or CT, or maybe we can switch to looking for the DAA. And currently, we have the DAA, so therefore, and for these patients, if they fail to the paclitaxel, we can select the DAA and choice for, because it's a genotyping 3, maybe sulfosbuvir combined daclazazovir could be preferred for these patients.
So Sengi, if I could just ask you, if you were just in the interferon ribavirin era, would you use ribavirin in this patient or not? Just use PEG? And what dose would you use?
Okay, I think, hemoglobin of 6.8, well, how low can a hemoglobin get? So you're right, I think we'd be very reluctant to use ribavirin, but there's some additional things that you might want to consider before you decide whether to start treatment. I think one thing is IL-28B. Again, if it's a good responder, then that might tip you to consider treatment. The other thing is we know that he's got iron overload, and this is a poor response factor. So they should really do the iron depletion therapy, more deferoxamine, get the ferritin down as far as possible before starting treatment. So those are the things you'd consider. And if you're going to use ribavirin, maybe just a hint of ribavirin, maybe 1 tablet a day.
If I may, I have a more fundamental question for actually Jacob and my friend Manuel here, the NASH experts. And I'm a little intrigued and actually bothered by the fact that we readily accept FibroScan readings across all categories of patients. How sure are we that this patient has cirrhosis? Because you have an iron overload, and just like steatosis, it could potentially give you a high reading. And I think we have to be a little cautious. I mean, I've seen patients with steatosis have high readings, and when I do a biopsy, and I use a 14-gauge manual TrueCut needle, I'm probably the last of the people who do that, so there's very little false negativity for cirrhosis, and I see stage 2. And then I do a FibroScan, it says 20. So the biopsy is falsely negative, or the FibroScan is overreading this in those with steatosis? So I would like to analogously look at this case as perhaps the patient not having cirrhosis for certain, and this is the kind of case I'd like to do a biopsy before I pass judgment. That's my 2 cents.
So I guess, Raj, what you're saying is based on whether the patient has cirrhosis or not would greatly impact your decision to treat if interferon was the only option. Exactly. Yeah. Manuel, your experience with FibroScan, how good is it?
I completely agree. If I have FibroScan and liver biopsy, I'm sure I'm making decision according to liver biopsy. FibroScan is a very nice tool, but we need to interpret cautiously and in a very strict manner. We need all time, for example, here is the success rate is 100%, perfect. The IQR is 1.2, the stiffness 14.4. This is a very, very high quality FibroScan, has all the requirement that we need to believe. But I agree, Professor Reddy, that in this case, 14.4 could not be enough to reach the diagnosis of cirrhosis, taking account all the impact of this diagnosis in the therapeutic option. And I think it's not a bad idea to confirm this cirrhosis. For example, using serum blood test, for example, or even liver biopsy.
I guess
because the ultrasonography was normal, was not diagnosis of cirrhosis. The ultrasonography of the liver was normal. No, the ultrasonography.
For this case, we did ultrasound and CAT scan, but I didn't show the CAT scan, and it showed mild normality and hypertrophy of left lobe and hypertrophy of right lobe. So I think this case already had a cirrhosis,
And
but
this
we did not do a liver biopsy for this case, but we do only EGD for EV surveillance, and it showed mild EV, mild esophageal varices, grade F1.
Sure.
Yeah, I mean, I think this is an important practice point that Raj raised about how useful and how much you can believe a FibroScan. My own view is that really FibroScan is just one tool in your armamentarium, and it's a gestalt, it's everything put together that makes a difference. In my best case, I've had patients, one patient in particular I remember with a FibroScan of 13 on methotrexate, so we did a biopsy, and it said F0. I didn't believe it. I actually, the patient had a laparoscopic wedge biopsy, and it was still F0. So I think the danger is to use FibroScan in the same way we use a viral load, that it's 100% the virus is there or the virus isn't. I think FibroScan is one of those where you have to use clinical judgment in with the other factors. And I think in this patient, the other problem is they could have extramedullary hematopoiesis. And so if there's expansion of the liver parenchyma, it's equivalent to like having heart failure or fluid overload, and that could artificially increase the FibroScan. Senki?
And I think, it's going to be affected, FibroScan is going to be affected by whether you're fasting, not fasting, whether you exercise, all this, amongst other factors. So we know also that the meta-analysis show that the FibroScan likelihood ratios are around 5 to 6, at best 7 for F4. So that is not a very certain diagnosis. In fact, other than liver biopsy, which patients really hate these days, is I send these cases for MR elastography. So that has got a likelihood ratio of around 9.9, and it's far more accurate. So, however, this case has got iron overload, and that is one of the situations where MRE can't be used accurately. So then you have to revert back to liver biopsy.
So Raj, any perspectives on treating this patient in the DAA era?
Well, I would have no choice.
Genotype
to
3.
use declarativir and sofosbuvir is what I would use. I would be reluctant to use interferon in this patient. So it would be DAC and sofosbuvir without ribavirin for 24 weeks.
And 12 weeks, 16 weeks, 24 weeks?
I would want to err on the, more conservative, well, not conservative is not the word, so be more inclusive, and I'd go with 24 weeks if I had the drugs available.
So Manuel, any comments?
Yes, I completely agree. Interferon and ribavirin, they are contraindicated in this patient, and we need to use DAA. Until now, the best result in the available drugs are the combination sulfos-Douglas, and we need to keep in mind that if it's truly a cirrhotics, we have a higher chance of achieve SVR.
So can I get a comment from different regions of the world in terms of this 12 versus 24 weeks? In the US, can you just use whatever treatment duration you want in this sort of a case where there are other factors such as thalassemia, etc., and you want to be careful? And maybe then take a comment from Sengi, what would happen in Singapore, and then also from Manuel.
As you know, we've been in the declarativir era only for about 6 months. So we're getting to learn about approvals, but we wouldn't get it for 24 weeks because of the hematologic issue and non-response. We'd have to sell the 24-week request based on cirrhosis. So we said we had cirrhosis, then they'll give the 24 weeks. Otherwise, we would not get it.
Singi?
Well, that's going to be a tough one for us because, you know, soft declatosphere 24 weeks, we're looking at big bucks here because sofosbuvir costs 95,000 Singapore dollars for 3 months course, double that, that's almost 200,000. Add on declatosphere, that costs you 16,000 for 3 months. So that's already about $250,000 for 6 months treatment. Not particularly cost effective. So if possible, I mean, the other alternative is soft PR for 3 months, right? For genotype 3, of course, in this setting, you're going to have trouble using ribavirin. So you might have to dose adjust the ribavirin. But soft with PEG-RIBA gives 87% SVR rate in cirrhotics genotype 3. So there's a possibility of extending it maybe 1 additional month to try and improve the SVR rate. So that's certainly possible, but this patient's going to be tricky and you'll have to manage the hematology very closely.
So Manuel, in Spain, do you have any restrictions in terms of duration?
No, even we have a paradox or a crazy situation or a nice situation because we pay the same for 12 or 24 weeks. We make decision clinically and we pay just the complete budget for the treatment of the patient, irrespective of the treatment duration. In this case, we use just clinical data to make a decision, but I completely agree with both different situations in Singapore and United States.
And Relay, in China, would you send the patient or try and get access to sofosbuvir, declatosphere from elsewhere?
And not yet, and the ORDA is on clinical trial currently. But, you know, in the nearby countries, they have some DA approved, so therefore, and you also have some patients, and they got the DA in nearby country, including Laos, Vietnam, India, and maybe Thailand. And due to the side effect and the long duration for pegloticase and combined with ribavirin, so therefore, even some patients come and have the high SVR, and due to the IL-28B, CCLL, most of the patients they went to the choice the DA.
Okay.
Thank you.
So I guess the answer from that clearly is that if we have genotype 3, we should move to Spain.
Okay, thank you very much for your comment.
Okay, so you got some, all right, that brings us to the end of this session, and thank you to the 3 presenters and to our guest panel.